Okay, welcome everyone. Thanks for joining us tonight. We're going to do some mock orals for the general surgery boards, focusing on colorectal scenarios. I have the pleasure of introducing our two examiners. Dr. Gifty Kwakji is an associate professor at the University of Michigan. More importantly, she was my fellow when I was at the University of Minnesota, and so I love working with her now in Ann Arbor. At the University of Michigan, she serves as the clerkship director for the surgery department and the director of medical student programs in the Office of Health Equity and Inclusion. Dr. Kwakji obtained both her undergrad and medical degrees from Yale University and holds a master's in public health from Johns Hopkins. She's both board certified in general surgery from the Harvard Brigham program, as well as colorectal surgery from the University of Minnesota. Her clinical expertise is in the treatment of colon and rectal cancer, inflammatory bowel disease, anorectal disorders, and utilizing minimally invasive approaches to address colorectal disorders. Her research interest lies in improving health disparities globally, tackling colorectal cancer screening and addressing treatment outcomes amongst populations in Africa, but also amongst immigrants here in the United States. I also have the pleasure of welcoming Dr. Cyrus Jahansus. He's an assistant professor at the University of Minnesota and my former chief resident and research mentor. He obtained his undergrad and medical degrees from the University of Virginia. He completed general surgery residency at the University of Minnesota and colorectal surgery fellowship at Cleveland Clinic, Florida. In addition to his clinical pursuits, Dr. Jahansus has an interest in understanding the roles of the intestinal microbiome in health and in disease, which stems from his passion for treating pathologic conditions of the GI tract. Last year, he was the recipient of the Asker's Career Development Award, which supports his goal to establish a protocol for repopulating the intestinal microbiome at the time of colorectal surgery to enhance patient healing and recovery. I also want to thank Ibram and David for being our tributes tonight. And so we'll get the evening started with Dr. Jahansus and Ibram doing some scenarios for us. Carry on. You're muted, Cyrus.
Starts off fresh. So thank you very much, Matt. I think Dr. Steele had a tweet earlier today about, or maybe yesterday, about his 10 rules for approaching the board scenario. And I thought that was extremely helpful. Main things are that we're not trying to trick you. Just demonstrate your logic in thinking through cases and staying safe. I think it's important that when you're faced with questions, you can take a minute to think about things and then present your thoughts and your approach in a cogent fashion and go from there. So Ibram, we'll go ahead and get started. First case, you are called by the ER to evaluate a patient with abdominal pain. The patient is a 56-year-old male presenting with a 3-day history of left lower quadrant pain. The pain began as a dull ache, but now has become more focal. He's otherwise healthy, denies fevers or chills, and his last bowel movement was yesterday evening. He has had some loss of appetite. He has never had a colonoscopy and denies family history of colon cancer. How'd you like to proceed?
So I'd begin by going down and assessing the patient, starting with a history and physical examination. Right off the bat, I want to get a set of vitals to establish the hemodynamic stability of this patient and assess and resuscitate them appropriately. Make sure they have 2 large bore IVs, that there's fluid available if necessary, and then proceed to take a history, clarifying the nature of the pain and any sort of relevant pertinent positives or negatives. You mentioned most of them in terms of things I'd be interested in: family history, previous colonoscopy. I'd like to know about any other GI pathology in his history, history of IBD, UC, ulcerative colitis, and then symptom-specific factors, including any bleeding per rectum, in addition to the pain, any vomiting, obstipation, and proceed with a physical examination focusing on the abdomen.
Okay, so main things are as stated in the history, no blood in the stools, otherwise just this progressive focal left lower quadrant pain. Vital signs are notable for a temperature of 99.3, heart rate 86, blood pressure 135/85, statting 98% on room air. Abdominal examination is soft, focal tenderness to palpation in the left lower quadrant, no guarding, no peritonitis.
Perfect.
How'd you like to proceed?
I would get a set of labs, including complete CBC, BMP, a lipase, LFTs, and proceed with a CT scan of the abdomen and pelvis with IV contrast.
Labs are notable for a white count of 11. Creatinine is at his baseline of 0.9. Everything else is normal. CT abdomen pelvis with IV contrast shows a short segment of inflammation of the mid-sigmoid colon without signs of perforation, free air, or free fluid. How'd you like to proceed?
So this patient is showing signs of diverticulitis, or what looks like diverticulitis. He's hemodynamically stable. His abdominal exam shows only focal tenderness. He doesn't have any history of immunosuppression, no fevers, and white count is relatively, just at the upper limit of normal. I have two options. Doesn't seem, if this patient's able to tolerate oral diet, I would give him an oral diet and see if he's able to tolerate at least liquid. And that'll be my indicator if I can send this patient home on oral antibiotics. There is also a discussion that I can have with him about non-antibiotic management of this disease, but I still think that that's not widely adopted. And so I would err on the side of caution and give him a 10-day course of Augmentin.
So what would you like to do then?
In the absence of anything concerning, which I have, based on what I've given, there's not much there to admit for me to admit him. I would give him a trial of liquid diet, and if he tolerates that, send him home on a 10-day course of Augmentin.
Okay.
The colonoscopy in 6 to 8 weeks.
Okay, so you do that. He does well. He goes home. Okay, so let's change up the scenario. Let's say instead on presentation, he states that he has not eaten in a few days. His last bowel movement was 2 days ago. He's been feeling progressively more distended with that. His temperature is 100.5. His heart rate is 100. His blood pressure is 130/80. He's satting 98% on room air. How would you proceed in this case?
The CT scan finding is the same, equivalent.
Okay, so you repeat the abdominal examination and CT scan in labs. Your abdominal examination is notable for tenderness to palpation in the left lower quadrant with guarding without diffuse peritonitis. You repeat the labs, notable for a white count of 14. Creatinine is 1.1, up from his baseline of 0.9. CT scan shows inflammation of the sigmoid colon with an associated 5-centimeter pericolic abscess, no gross free air.
So this patient needs to be admitted and started on intravenous antibiotics. I'd start him on broad spectrum, such as piperacillin, tazobactam. Make sure that he gets fluid resuscitated with a liter bolus of crystalloid and start him on a drip. I would keep him NPO with bowel rest, and I'd consult my colleagues in interventional radiology about possible drainage of this 5-centimeter abscess.
Okay, so you do all that. The following day, IR comes in and places a percutaneous drain into that collection. And upon placement, you appreciate purulent drainage. Patient does well. You send him home after tolerating diet on hospital day 4. How would you manage the drain and long-term the patient?
So I'd continue this patient on a course of antibiotics for at least 10 days. Transitioning to oral antibiotics. The drain, I would remove it once the drainage stops, once it's no longer putting out anything purulent. Ideally less than 10-15 cc's a day of discharge. I would then remove the drain in the clinic. I would get this patient an outpatient colonoscopy in 6 to 8 weeks, and I would discuss elective sigmoidectomy with the patient.
Okay, and tell me about the operation you'd offer, and when would you perform that operation?
So I would offer them a laparoscopic sigmoid resection with a colorectal anastomosis. I would offer this surgery at least 2 months out of the initial insult to let all the inflammation cool off.
Okay, so let's back up the scenario again. Let's say he presents with nausea, vomiting, distension, temperature of 102, heart rate in the 110s, blood pressure 110/70, satting 92% on 2 liters nasal cannula. Physical examination, notably the abdomen, is remarkable for diffuse tenderness to palpation and a rigid abdomen. How would you like to proceed in this case?
This patient is presenting with signs of generalized peritonitis, fever, and tachycardia suggestive of sepsis. So again, an initial approach would be similar in terms of IV fluid resuscitation, broad spectrum antibiotics, but this is a patient that I would take to the operating room.
Okay. Okay. And so what operation would you like to offer this patient?
I would consider, I would offer them a laparoscopic colon resection with possible stoma, explaining to the patient there's a very high probability that I'm going to convert to open. I think I'd be curious to stick a scope in and see what it looks like, but likely there's a high likelihood that I'm going to convert this to open and he'll need a stoma, whether that's primary anastomosis with diverting loop ileostomy or an end colostomy, but that decision would be made at the time of surgery and based on their hemodynamic status.
Okay, so you entered the scope, immediately you see free feculent peritonitis, you convert to an open operation, and you perform a Hartmann's operation, perform the sigmoidectomy with an end descending colostomy. What are the complications of this operation in this setting?
So there's a risk of anesthesia and then procedural related risks. So when I'm consenting him, I would just tell him the risks of anesthesia, including DVT, PE, stroke, MI, pneumonia, as the major risks. In terms of procedure specific risks, there's a concern about damage to ureters, damage to surrounding structures that may require repair, such as small bowel or colon. Risks of this colostomy not being reversed down the road. About 50% of end colostomies don't end up getting reversed. Rectal stump blowout and wound infection.
Okay.
Deep space infection as well.
Oh, okay. All right, let's go on to our next case, case 2. You are in clinic. You are seeing a 62-year-old female who's presenting with a 2-month history of blood mixed with bowel movements associated with loss of appetite, as well as a 10-pound unintentional weight loss. Past medical history is otherwise unremarkable. Family history is unknown as she was adopted. How would you like to proceed?
So this history is concerning for malignancy. I would make sure I take a thorough history of the presenting illness, if there's any other additional symptoms, in addition to the bleeding and weight loss, any obstructive symptoms that she may have experienced, any change in the caliber of her stool, history of previous colonoscopies or previous colonic or abdominal procedures, and any personal history of inflammatory bowel disease or UC. I would then proceed with a physical examination of the abdomen and order a colonoscopy for this patient.
Okay, so she's never had a colonoscopy. Everything else is negative. She's never had any surgery. She might be having thinner caliber stools, but she's otherwise not had, she denies any nausea, vomiting, distension. Vital signs are normal. Temperature 98, heart rate 90, blood pressure is 110/80. The abdominal examination is normal. Digital rectal examination without hemorrhoids, but you appreciate stool mixed with blood on your finger. And then you mentioned colonoscopy, is that correct?
Yes, correct.
Okay, she says she's never had a colonoscopy. You order that colonoscopy, you perform it yourself. The colonoscopy identifies on colonoscopy, you identify a 4-centimeter partially obstructing fungating mass in the mid-sigmoid colon. You are able to traverse the mass, the cecum is otherwise reached, and the remainder of the examination is normal. You biopsy the sigmoid tumor and tattoo distally. Pathology returns as moderately differentiated adenocarcinoma, intact mismatch repair genes. How would you like to proceed now?
So I would proceed with staging of this patient with a CT chest, abdomen, pelvis, and a CEA.
Okay.
And then I would discuss the patient at tumor board and proceed from there.
Okay. So CEA is 12. CT chest, abdomen performed. CT chest, abdomen, pelvis performed, identifies the mass in the sigmoid colon corresponding to your colonoscopy, but otherwise negative for metastatic disease.
So I would offer this patient laparoscopic anterior resection I would like to refer to pre-op clinic and make sure I get some nutritional markers on her as well, given the weight loss. Make sure that her protein, albumin, prealbumin are at least at a reasonable level, and let her know that there's always a risk of a stoma involved with this procedure.
Okay, all labs are normal. Hemoglobin is 10.
Okay. Depending on the lead time between surgery and booking the patient, I can start her on iron supplementation. I'd need at least 2 weeks of a lead time for it, to give any sort of a benefit with IV iron. And ideally, I'd like to operate on her in a shorter period of time. So I don't think I would do much for that hemoglobin.
Okay, and so you mentioned your operation. Can you describe the main steps of your operation and how you'd like to do it?
Right. So I place the patient in lithotomy with arms tucked. I would request to have a colonoscope in the room. I would prep and drape the patient in the usual fashion. I would enter the abdomen through, barring any previous abdominal surgery, 10, 12 millimeter Hassan port at the umbilicus. Place the remainder of my ports in the right lower quadrant, right upper quadrant, and in the epigastric sort of left upper quadrant area. I would identify the IMA pedicle, incise the peritoneum underneath it at the sacral promontory, and then begin developing my medial to lateral plane, dropping down the retroperitoneum and separating it from the overlying mesentery. I'd identify the left ureter and make sure it was preserved. Once that was complete, I would then transect the IMA, perform a high ligation of the IMA with an energy device. I would then take down the lateral attachments of the colon, of the descending colon, up to the level of the splenic flexure. I would assess my reach at that point and decide on whether I'd need to do a full splenic flexure mobilization. I would divide the colon at least 5 centimeters proximal to the tumor, and likewise 5 centimeters distally, assessing my vasculature and ensuring that I take my entire IMA pedicle with its lymphatics. I would then perform end-to-end. I would exteriorize the specimen, remove the colon, place an anvil stapler of an EA 29 stapler, and perform an end-to-end anastomosis, colorectal anastomosis.
Okay, so you do all that, patient does well, pathology returns as a T3N0 cancer. How would you advise the patient based on this pathology?
So this kind of falls into that gray area of a stage 2 tumor. I would discuss the benefits of potentially chemotherapy, adjuvant chemotherapy with the patient. I'd like them to meet with a medical oncologist to discuss that a little bit further. Given their age and overall, my understanding is this patient is in good health overall.
Correct. No other personal history of any disease.
Again, it would be an individualized answer, but a decision. But there is a role for adjuvant chemotherapy in this patient. It would be a discussion with medical oncology.
Okay, what if the pathology returned as a T3N2 cancer? How would this change your recommendations?
I would be strongly in favor of adjuvant chemotherapy.
And what would your adjuvant chemotherapy be?
8 cycles of FOLFOX.
Okay, and then you do all that. What is your post-operative cancer surveillance?
So they'll need a physical examination every 3 to 6 months for 2 years, and then every 6 months after that for the next 3 years. She'll need a CEA at those 3 to 6 month intervals as well, for the first 2 years, and then every 6 months for the next 3 years. She'll need a complete colonoscopy at 1 year, and then if that's normal, the follow-up will be 3 years later, and then 5 years after that. CT scan of the chest, abdomen, and pelvis annually.
Okay. All right. So let's back up that scenario. Let's say the colonoscopy identification was the same mid-sigmoid tumor, moderately differentiated adenocarcinoma, but on staging, particularly CT of the chest, abdomen, pelvis shows two 2-centimeter lesions concerning for metastatic disease. How would you proceed in this case?
The lesions are in the liver or the lung?
Liver.
In the liver. And so I'd have to discuss this patient at a multidisciplinary tumor board, ideally with the hepatobiliary colleagues involved. I'd like to know which segment of the liver those lesions are involving and whether that's something that they would consider resectable. And then at this point, it would be a discussion of neoadjuvant therapy followed by either a two-stage resection or a single-stage procedure. It's a bit of a nuanced decision, so I'd like to have my colleagues involved in that, but this is something that I would still treat with curative intent, ideally with upfront adjuvant chemotherapy followed by resection.
Okay, so what would you tell the patient?
So I would tell the patient that we need to discuss this she needs to see a liver surgeon, she needs to see a medical oncologist, and we kind of need to, discuss this together. But I would offer, my bias would be towards neoadjuvant chemotherapy, followed by a staged liver and colon resection.
Okay, so she sees the hepatobiliary surgeon. It's right lateral lobe segments. Both lesions are easily resectable at this time. You mentioned you'd proceed with neoadjuvant chemotherapy. Is that correct?
If they're easily resectable on the right liver, you can proceed. I would proceed first with a metastatectomy followed by chemotherapy, and then we'll deal with the colon at a later date if it's not completely obstructing.
Okay, so the liver lesions are resected. She undergoes adjuvant chemotherapy, and then so she's seeing your office. She's in your office now. How would you like to proceed?
So I'd like to restage her now following chemotherapy and the liver resection, again with a CT chest abdo-pelvis, repeat a CEA, and then discuss operative resection with the patient, again, a sigmoid colectomy. Depending on the initial procedure, likely I would try laparoscopic as well with a possibility of open conversion.
So restaging shows resolution, no evidence of any metastatic disease, notably in the liver or anywhere else. Still shows that persistent thickening at the sigmoid colon at the known site of the primary tumor. And so at this point, your recommendation in terms of operative intervention would be what again?
Laparoscopic anterior resection.
Okay, so let's say instead of, at the time of colonoscopy, we'll back up again. You identified a 4-centimeter partially obstructing fungating tumor at the middle rectal valve, 9 centimeters from the anal verge. You proceed with your staging once again. How would you stage the patient in this case?
I'm able to get through it, and there's nothing else in the colon, the rest of the colon?
Correct. You're able to traverse it. It's easily traversable. No other evidence of any other synchronous tumors at this point in the colon.
So it would be similar in terms of a CT chest, abdomen, pelvis, and a CEA, but I'd also need to get an MRI of the pelvis.
Okay, you do that. The CEA is 12. The CT cap shows no evidence of metastatic disease. The MRI shows a 4-centimeter rectal mass corresponding to your colonoscopic findings, T3N2. How would you proceed?
So I would present this patient at a multidisciplinary tumor board. My recommendation would be neoadjuvant chemoradiation. Depending on the institutional practices, there may be a role for TNT, total neoadjuvant therapy, but at minimum, she would require neoadjuvant chemoradiation followed by proctectomy with a diverting loop ileostomy and adjuvant chemo.
Okay, so she undergoes her the chemoradiation therapy. How soon after that would you offer the proctectomy?
8 weeks.
Okay, so 8 weeks is time. She's seeing you once again for surgery. What surgery would you offer her?
I would offer her a laparoscopic low anterior resection with a diverting loop ileostomy.
Okay, and can you state for me the main steps of that operation?
So similarly, gaining access to the abdominal cavity, placing my ports, identifying the IMA, creating a peritoneal flap at the sacral promontory, dissecting up the mesentery from the retroperitoneum, identifying and preserving the ureter, dividing the IMA at its root, and then following the superior rectal artery down, mobilizing the rest of the colon and following the superior rectal artery down into the pelvis, into the presacral plane using sharp dissection, to perform a total mesorectal excision with at least 5 centimeter distal margin. If it's at 9 centimeters, I think I could get a 5 centimeter distal margin and just perform a partial TME safely. I'd confirm that endoscopically with a flexible sigmoidoscopy intraoperatively, make sure I perform an air leak test and bring up a diverting stoma.
Okay. Well, I think I got that. Well, excellent. I think we're all done. Matt, I think we're just about done with time. Is that right?
Yes. So you can go ahead and give some feedback, and then we'll switch over to our other group.
Perfect. So overall, I think you did well. You clearly know everything. I think the main points I have for you are stylistic. And what I'd like for you to do is, obviously, this is high pressure, and I think you did great under these circumstances, and I appreciate your doing this. The main things are, with the answers that you have, you know everything. I would say tighten everything up. What I would not say would be either ors, because you're giving the examiner pathways that they could take you where it'll get you into a little bit of trouble. I want you to, for everything you have, I want you to have a specific answer. So for example, you're right, TNT, institution, all that. But either way, if your answer is going to be chemo, radiation, then surgery, then adjuvant chemo, that's what you say. Don't even mention TNT. Or if you just want to go with TNT, I would say chemo, radiation, consolidation, chemotherapy, and then surgery as you did. Okay. So I would be direct and succinct there. I think the other thing, so main things I have for you, stylistic, and then the other thing is now what's been an evolution over the last few years with the board cases are that they're giving you a lot more of the information up front. So if I'm giving you more detailed stuff, I would take that as face value unless I don't mention something that's important, like the second patient. You saw it. I didn't mention whether or not she had had a colonoscopy, and that was great that you picked up on that and did that. That was a critical thing there. I think so. That was the second thing. The third thing I had for you, I would say, for the operative steps, I think you know all the major steps. I would just highlight the major steps. I would say laparoscopic. I'd find the IMA ligation, splenic flexure, ensuring tension-free, get my proximal distal margins of the tumor, create an end-to-end colorectal anastomosis with the EEA, and don't forget about your leak test with the flex sig or proctoscope, however you prefer to do it. And I would just highlight those points because I think if you start mentioning too much about 10 to 12 with a Hassan or the other ports, then that's not where it's going to get you the points there necessarily. It's looking, they assume you know that stuff. It's the critical steps of the operation. I think that you could just highlight there. If there's other stuff they want to ask about, they'll get you there. Otherwise, I think you passed. I think you passed both cases. I certainly did not have any critical fails there. The hepatic Mets one, that was probably a little bit tricky. And you're absolutely right. There is gray areas there, but once again, which each of these things, don't give the examiner options of what you do. Pick your case. I certainly think if you've got metastatic disease there, you've got several options, right? You could do chemo up front. They're proving themselves to have metastatic disease. Certainly not wrong to give chemo up front. That's probably where institutionally we're probably, even with resectable disease, where we're going because it's stage 4. And then if the patient's healthy, you can decide exactly as you did, whether you want to do a staged sigmoidectomy with the hepatic metastatectomy there, or if you want to do it, concomitant or staged there afterwards. So I would just say you got everything, you got all that, your knowledge is clearly there. I would just, as you're doing prepping, tighten things up and kind of go from there. Gifty, did you have any other thoughts there?
I absolutely agree. Everyone, I thought you did an excellent job. It was really impressive hearing you speak and with the confidence with which you spoke. I agree with Cyrus that if anything is a stylistic thing, just committing to one path and say, this is what I'll do. And then the options, you just open yourself up for someone taking you down a rabbit hole. If you bring it up, then it's fair game. They can just pursue that and then definitely get yourself into trouble. So just pick one thing you know real well and then go with it instead of just opening up these multiple doors. And then I think everything you said, Cyrus, was excellent or accurate. Yeah.
Yeah, so I would keep doing that, and then so I think you're in great shape. Excellent.
Thank you.
All right, thanks, Ibram, and we'll switch over to our other examiner and examining.
Hi, David.
Hey, how are you?
Hi. Good, good.
Hey,
Okay, ready to go?
I am ready.
Okay, awesome. So you have a 47-year-old female. She's being referred to you in your clinic by her primary care provider for evaluation of rectal prolapse. The patient reports that over the past year, she's had this increasing sensation of something dropping out of her anus when she's having a bowel movement. Sometimes there is some associated bleeding. Occasionally, she says that she has to push the prolapsing tissue back in with her digits. She's not splinting. She's not having to shift her position on the toilet bowl. She says she's tolerating the diet. She has what she describes as a regular bowel movement for her, which occurs every other day with assistance of Miralax. The rest of her history, including her past medical, past surgical, and family history, is non-contributory. How would you like to proceed?
Okay. Yeah, sounds like you got a great history for me. The one other thing I would wonder is if she'd ever had a colonoscopy. I know she's 47, but
No
I would want to know if she'd
colonoscopy.
ever.
No previous colonoscopy.
Okay. And then I would proceed with the physical exam. So I'd do an abdominal and make sure we do a rectal exam as well in the office if she can tolerate it.
Okay, so you do an abdominal exam. What specifically are you looking for in your abdominal exam?
Any masses, lymphadenopathy. I'd also go down to the groins and look for lymphadenopathy or hernias. And then I'd want to know the size of her liver and spleen,
Okay.
any tenderness there.
So the abdominal exam completely fine. No enlarged lymph nodes in the groins. No tenderness and palpation of any of her abdomen. Describe to me your rectal exam.
Okay, yeah. If I have the table available, I would do jackknife positioning with an assistant to help me get exposure and good lighting. I'd start just with a visual exam, looking around the perianal area. Then I would do a digital exam, looking for any masses at this point. I want to see, obviously, if I can reproduce her prolapse on this. So I'd ask her to bear down. And then I would insert the anoscope as well. And again, looking around for any, rectal pathology.
Okay, so you do that. On your inspection of her bottom end, you notice that she does have some prolapsing tissue. How would you be able to tell the difference between a prolapsing rectum and a prolapsing internal hemorrhoids?
Yeah, rectum should have circumferential rings to it. Hemorrhoid should be more segmental.
Okay, so she has what appears to be a prolapsing tissue, which has radial folds to it. When you do your digital rectal exam, you feel that in the left lateral column, there is this fixed hard area. She's unable to tolerate an endoscopic exam in clinic, so you're unable to visualize it. When you remove your digit, you can see it grows blood on your glove. What would you like to do next?
Yeah, that's a concerning exam finding. So I would discuss with her the need for biopsy, and I'd like to do that in the operating room. So, discuss exam under anesthesia with her for biopsy of that.
So you do that, and you take a biopsy of this mass, and it comes back a few days later on confirming that this is poorly differentiated squamous cell cancer. What would you like to do next?
So I'd, obviously tell the patient what we found. I would begin with a staging of this cancer. So she needs a CT of her chest, abdomen, pelvis, and an MRI as well. And I would get a CEA, CBC, and a CMP.
Okay. Anything else you want to get?
No, but I reserve the right to change my mind later.
That's fair. Okay. So you get the MRI pelvis, and this shows that there's this 2 centimeter mass in that left lateral aspect. It is 1 centimeter from the anal veg, is involving both sphincter muscles. There are no locally enlarged lymph nodes. On your CT chest, abdomen, pelvis, there's no evidence of distant disease. You get your CBC and your LFTs, and those are all normal.
Okay, I discussed with her that squamous cell cancer typically responds very well to Niagara protocol, and I would refer her to, I present her at multidisciplinary conference and discuss getting that Niagara protocol for her.
Okay. Can you tell me a little bit more about the Niagara protocol?
Yeah, it's about 45 gray of chemotherapy, and then that's going to be over the course of 32 days. On days 1 through 2, I believe she gets chemosensitization there, so I think that's fluorouracil, and then she gets it again on days 29 through 32, and then she gets a bolus of mitomycin. But if I don't have the exact specifics, I'd let her finish that conversation with an oncologist.
Okay. So she goes through the treatment, and you get notified by the oncologist that she's completed it, and they would like you to see her back in clinic. When would you like to see her?
Yeah, somewhere between 2 and 4 weeks afterwards would be fine start.
Okay, 4 weeks. So she shows up in your clinic, you do another exam, and on the exam, you can still feel something hard in that left lateral aspect. What are you going to do?
I just need to know if it's even a little bit better or the same, and if it is, I would continue monitoring for another 4 weeks.
Okay.
And I'd monitor as far out as 6 months.
6 months. Okay. So she comes back to see you, and you've been following her, and then out as far out as 6 months. And this time when you see her, you can't feel or see anything on exam. Describe your surveillance protocol.
I would want to restage her with the MRI and the CTs, and then if all that continues to look like a complete response, then she needs anoscopy every 3 months for the first year. I would continue the CEAs every 3 months.
Okay. Will you get any imaging too along with those?
Yes, I would restage her with an MRI and the CT, chest, abdomen, pelvis initially.
And any additional interval after that?
Yearly after that.
Yearly after that. Okay. What if she came in at that 6 months point and she still had residual disease? What would you do?
Yeah, I would have to do the restaging still and see if we at least got it clear of those sphincters. But if it's still not clear of the sphincters, I would discuss with her the need for an abdominal perineal resection.
Okay. So you do your restaging and it's still involving the sphincter muscles. It seems as if it responded a little bit, but not much. So walk me through your preoperative planning and the main steps of the APR.
Yeah, before I go in there, and I would discuss whether she's going to receive a permanent ileostomy. I'd oversee the ileostomy nurse for preoperative marking, hopefully somewhere in the right upper quadrant, but somewhere where she can live with an ostomy bag pretty well. And then I would have my plastic surgery colleagues available as well, since she had her pelvis radiated for reconstruction afterwards. And then I would perform this with a lower midline incision. So I'd begin open. I would begin by mobilizing the sigmoid colon lateral to medial along, starting at the white line at the descending colon, and then just mobilize the sigmoid. I typically ask the urologist preoperatively to put a stent in on her. It would be just okay to do the left-sided stent, just so I can identify ureter injury if I were to get near the ureter there. Then I'll mobilize all the way down to the sacral promontory. Once I have that mobilization done, I would begin the total mesorectal excision. So I would get into the pre-sacral plane sharply, ensuring to again do this sharply and preserve all the sacral plexus, and then go all the way down to the coccyx posteriorly. I would try to connect that radially, ensuring not to cone
and a distal dissection and get up to Denovier's fascia anteriorly. Then I would go ahead and transect my sigmoid colon because I should have done a high ligation of the IMA there, so I would transect where it's obviously demarcating, and then take the now I have my mesentery dissection completed and I have my colon intra-abdominally done. So I'd let the plastic surgeon do whatever reconstruction he's planning on, whether that's a VRAM or a gracilis flap, and I would move down to the perineal part. So these patients I do in lithotomy. There's definitely no need to prone because I want to leave that available for the plastic surgeon to start working. And then I would palpate the coccyx. There I would purse string close the anus to prevent any spillage, make my teardrop incision, and then I'm going to follow the, I'm essentially going to go to the coccyx posteriorly and ensure that I have resected circumferentially all of the sphincter muscles, and then follow the levators all the way up again to the coccyx. And then once I've connected it posteriorly, I'll connect it circumferentially. At that point, I should be able to remove the specimen, through the perineal defect, and then just help the plastic surgeon with closure.
Right.
That should complete it.
All right, good. So let's back up a little bit and say, what if the staging had come back and had indicated that this patient had metastatic disease? How would you treat them in that case?
Metastatic even after they completed their Niagara protocol.
And this is before. Let's go all the way back. So when you saw them and you noticed a lesion, and then you got your staging CT scans. So what if it showed that they had metastatic disease?
I would discuss her early at multidisciplinary conference. I'm not sure that I would change anything unless they had another suggestion. I would still do Niagara protocol.
Okay, so let's change the scenario even a little bit more. And so we're going back even further. So let's say in clinic, you're doing your exam and the anal canal is fine. She has some hemorrhoids, they're bleeding, but you notice that she has this 1 centimeter lesion, which is around the anal margin. You do some staging for that, you get the same sort of staging, and this indicates that it's a T1, N0, M0 squamous cell cancer. How would you manage this?
Yeah, that's great. I think that's changed recently. So she could potentially get just the wide local excision of that lesion if it's truly T1, and avoid the Niagara protocol. Anything more than a T1, though, on the resection, I would still do Niagara protocol.
Okay, what margin?
A 1 centimeter margin per
centimeter
squamous cell. It should be plenty.
Okay, so let's go to our next scenario. So you are still in clinic. You seem to love clinic, but you're in clinic and you have a 65-year-old female. She is coming in with complaining about mild to moderately enlarged internal hemorrhoids, which have been bugging her for a while now. This is something that they've been trying to use, tox, hemorrhoid creams. It doesn't seem to be working. When you ask her, talk to her a little bit more, she tells you that she's been having bowel movements every 2 to 3 days or so. She has to strain a lot. Sometimes there's blood. This has been going on for several years, but it's progressively getting worse. And she is taking Miralax every other day. Used to be on Linces, someone had prescribed for her, but she stopped because there wasn't much improvement. There's no past medical, past surgical history that's significant. She had a scope previously that was normal. So you do a digital rectal exam. She has this mild to moderate hemorrhoids. When you do an endoscopic exam, which confirms that. What additional things do you want to do on your exam with her now that you have her in clinic for someone who's presenting with some internal hemorrhoids and constipation?
Aside from looking for hemorrhoids, that would really complete my exam.
Okay. And so you end up going ahead and then trying to do additional workup to sort of get to the bottom of this. What workup will you do?
I wouldn't really do a workout. I would start with just giving her a high fiber diet, so up to 40 grams of fiber a day, which is pretty aggressive. And if she fails that, then you know, I know defecography is a possibility in her, but if she's had a normal colonoscopy, I'd actually lean away from doing those studies and just try lifestyle modifications and then surgery if she fails that.
Okay. And what surgery would you do for her?
If these are completely internal hemorrhoids, we could band them in the office first. Again, if they don't respond to medical therapy, and then my other options, if they continue to recur, would be a stapled hemorrhoidpexy versus a hemorrhoidectomy.
Okay. Describe to me how you do your hemorrhoidectomy.
Okay, I do it, the hemorrhoidectomy, obviously in the operating room, and then begin with a digital rectal exam, and then I would place a medium Hill-Ferguson retractor. I want to know about all 3 hemorrhoidal columns, which ones are affected, and then I'd begin by removing the at least first 2 that are the most affected. Typically use a chromic suture on a UR6 needle. So after I've done my examination, I have an assistant hold counter traction. I place a pexing suture to ligate the hemorrhoid artery as proximal in the rectum as I can get on that. Then I just do a sharp excision of the hemorrhoidal column, making sure to take as minimal anoderm as possible since we might be going for multiple columns here. Then bluntly dissect that column off of the sphincter complex, complete the excision, and then run the chromic both out and in and tie it down to the tail that I left most proximally.
Okay.
I would do 2 columns. I would check with a medium Hill-Ferguson retractor, and if I still have, if I can still get the medium Hill-Ferguson retractor, and I know that I have not tightened her anoderm too much.
Okay. So you do all of that. You see her back in clinic in about 8 weeks. She's feeling great from the hemorrhoid standpoint, so that's been good. But she still is complaining about inability to poop. She's like straining, still not going great, spending a lot of time in the bathroom. She says it takes about an hour to 2 hours for her to like have a bowel movement. She's now miserable, and she's asking for your help.
So you said she'd had a recent colonoscopy?
Mm-hmm. And that was normal.
And she's failing fiber therapy? Okay. I would do a CT of her abdomen and pelvis and then defecography to see if I can understand the anatomy a little bit better here and the functional component.
So you do a CT scan of her belly. That doesn't show anything significant, aside that she has like some poop in her colon, but nothing that is anatomically off. On the defecography, so that one shows that she has an internal rectal intussusception. There is no external prolapse. With repetitive attempts, she's able to empty her rectal vault. Since she's there and they sort of do the studies in the same place, you do also order an anorectal manometry. And on that, her sphincter muscles, the strength is okay. She has an abnormal balloon test, which shows hyposensitivity, and it confirms that she has some pelvic floor dyssynergia. What would you like to do next?
Okay. Yeah, I would definitely be out of my comfort zone with that. So I would discuss her at GI conference. It's certainly not an emergent thing, so I would probably refer her to somebody more comfortable with those findings.
Right. And so then you send her to see someone else. So let's change the scenario a little bit. So she, as part of your workup for her constipation, you get a colon transit test. And the colon transit test shows that she has slow transit constipation. Her pelvic floor is completely okay, but she's not moving things through her colon that well. How would you manage that?
Again, out of what I would do clinically, but from what I understand, promotility agents are a way to start, but they probably have a limited effect. And then if we could tell that there was a specific part of her colon that would dysmotility, I would lean more towards a resection of that.
Okay. And then would you do just a segmental resection, or would you do
Yes.
a total resection?
Just a segmental resection, and this,
Segmental
as long
resection.
as I had nothing else on the colonoscopy.
Okay. Now, what if this was an 87-year-old female who had a pretty decent cardiac history, but was coming in with a 5-centimeter external rectal prolapse? How would you manage her?
Okay, I'd do the history physical exam. Most particularly, I wanted to know is this prolapse ischemic at all?
Okay. So you do that, and is not ischemic in clinic, but she's clearly symptomatic from this. So you elect to do some operative approach to repair this. What would you do for this?
Okay, on my history, I would just want to know what kind of abdominal exam she has. And you said she said she had a cardiac history that was pretty significant.
She had a significant cardiac history, but if needed, the cardiologist will clear her for this. Rest of exam shows nothing else on history. She's an 87-year-old female. The cardiologist says if she needs this, you can do it. We'll optimize her.
Okay. Yeah, certainly high-risk patients, I would consider avoiding anesthesia at all. But if the cardiologist thinks that she's not even close to high-risk patient, I would discuss with her the options. I want to know kind of her family history, how long people in her family typically live, because the biggest surgery is intra-abdominal and gives her the longest lasting results versus just a local excision of the redundant rectum. So I want to try to get an idea of the length of life in her family.
In her family?
At 87, she's planning to live to 100, and I would discuss with her the sigmoidectomy and rectopexy.
Okay, sounds good. Okay, so why don't we stop there, and then let's get, so overall, I thought you did a decent job. The second case was a bit tricky. So the second case was, and we'll get to that, but that was a lot to do with like pelvic floor, constipation, kind of management of those elements. The first case was the anal cancer. We did anal canal, and then we shifted to anal margin. And you have the general, in terms of knowledge and information for that, did much better on that case than the second case. So in terms of exam items, so when I gave you the history, you asked if she had had a previous colonoscopy before. But then when you went to your workup, you didn't ask for a colonoscopy. So clearly you had thought about it as being something that was important, but you didn't follow up with that. And in a lot of the patients who have anal squamous cell cancer, we know that one of the risks is like HIV or some other thing that is an immunosuppressive. So getting an HIV test just to make sure that we're not missing something like that, that can also help with their medical management. And in women, I would advise that you also have them see an OB-GYN specialist to have like a pap smear or pelvic exam to make sure that there isn't extensive disease into the middle compartment, which then they might get additional treatment for as part of their NIGRA protocol. So those would be like the additional things. In the guide, the recommendations that you also do like a genitalia exam just to make sure they don't have other lesions on their penis or their scrotum, that also needs to be addressed in your field of treatment. So in terms of the NIGRA protocol, it's the 45 gray for the radiation, usually over a 5-week period. And then it's usually combined with 5-FU. And then they give different doses, day 1, 4, and then days 29 to 32. And then you also add mitomycin C to that. And so that also has its regimen, but that's the NIGRA protocol. For your surveillance, so I think that's where you struggled a little bit. And I'll encourage you to look up the NCCN guidelines. There's a whole algorithm in terms of how we surveil them. You were right that I think you mentioned you bring her back in 4 weeks, but that would be too soon. Typically, when I see them back during that time frame, there's always something that is not cleared. So the guidelines is that you bring them back in about 8 weeks. And so then you start your subsequent, and then you bring them back, as you mentioned, until 6 months, and then you decide on what to do at that point. And then in terms of after you've decided if they've had remission, Then you go on to this whole every 3 to 6 months, you're seeing them for different things. You're doing inguinal exams, the endoscopic exams. There's a whole schedule for doing imaging too with that. And then depending on what happens, you switch. I asked about metastatic disease. And so that one, usually you treat with like the chemo because they have distant disease. So just focusing on the local disease is not really going to help you that much. But usually we'll combine, if they have like metastatic disease, you end up doing like some additional chemotherapy for that. And then let's see, what other question did I ask you here? Oh, when we switched it to anal margin. So you were right with that in terms of the staging, and then the 1 centimeter margin that you would take with that. So that was definitely correct there. When it came to describing the steps of the operation, I thought you spent too much time with that. I think you could have trimmed that really quickly. I like that you brought in urology. You mentioned urology, you mentioned plastics. I was going to try and trip you up and have you close the wound yourself if you hadn't brought that up, and then the patient would have shown up with a wound complication. So the fact that you had plastics involved, I think, especially for someone who's had radiation before, but trimming it down and making it very succinct, just going through those steps would be good. So I'm trying to rush so that we can get to the second case just based on the amount of time that we had. So there's a patient who is coming in with hemorrhoids, their complaint is hemorrhoids, but then I gave you all this additional history to suggest that she has constipation. There's something wrong with her. It could be she's already tried some Miralax and she's been on Linzess, which is one of those like promotility agents the GI doctors like to use. And so something is definitely wrong with her. And you had mentioned that, you know, a DEFO might be helpful, but because she has a normal colonoscopy, you wouldn't get a DEFO. And I feel like those are looking at two separate items. The colonoscopy is looking for intraluminal pathology. The defecography is trying to evaluate the pelvic floor. You know, we could go into all these details about constipation, slow transit versus obstructive defecation, but I would encourage you to do a little bit of reading around that, because that's definitely something more and more colorectal surgeons are managing. So anyone who's coming in with some constipation sort of symptoms, you could address, do what you did, the dietary changes, the lifestyle modification. That doesn't improve. You want to take off the hemorrhoids, you can. But I would suggest that you do those additional tests to figure out what is driving the constipation. The defecography, internal rectal intussusception, some people treat that surgically. Certainly at University of Minnesota, that's something that they specialize in. So a lot of these patients get some sort of treatment, and it'll be a ventropexy. They usually do it with mesh. Some people wait until they have like truly external prolapse before they will do something to manage that. The slow transit constipation, so that one is the whole colon is not working. So you can't do a segmental resection. You have to take out, if you are going to take out the colon, then you have to take out the entire colon. You can't do a segment. I remember on my oral boards for colorectal, I had the same question, and the situation was, if you didn't do a pelvic test, then you'd have a slow transit constipation person. You take out their colon, connect their ileum to their rectum, and then a few weeks later on, they have an anastomotic leak because they had a pelvic floor that wasn't working, backed them up, and then they leaked. So you always have to do the slow transit or evaluate your colon in addition to evaluating your pelvic floor, or they're going to get you one way or the other if you don't do a complete constipation workup. And then when it comes to an 87-year-old female, I try to make her sick a little bit so you lean towards doing an Altmaier, because that would be like the safest thing. Although now with all the improvements in technology and all the systems that we have, you could argue for an intra-abdominal procedure, but typically most people will say they'll do an Altmaier. And then I was going to ask you to review the steps of an Altmaier with us, okay? So I would say the anal cancer did much better. Review the constipation stuff. Pelvic floor is becoming, I feel like everybody gets a question on that in the oral exam. So just make sure you review that. And then how we manage it. We have pelvic floor physical therapy, biofeedback. You can have people do, there's so much you can do with the pelvic floor now. Cyrus, any additions there?
No, I totally agree with that. I think some of the things tighten things up as well. I think if you show any hesitation in there, or you say either or, as Gifty said before, you're gonna give them free game to attack you. I would say no colon, rectal, anal, NCCN guidelines, and at least algorithms for which way they can take you, but certainly the postoperative surveillance there. And then I think one trick, as Gifty was mentioning, the pelvic floor is becoming really, is becoming critical, and having a bit of an algorithm there to evaluate where you're going with that will be really important for here. And nothing crazy. I think one of the ways that helped me think about it was thinking from distal to proximal. You got to rule out pelvic floor pathology. Obviously, the paradoxical contraction here where Gifty was going there. And so then you really have to, you fix that with, and you wouldn't have known that until you do the gamut of testing, where certainly you got to rule out colonoscopy, but then anal manometry, X-ray defecography to give you that anatomic as well as physiologic functionality there. And then you're never wrong for, if you're ruling out a malignancy, you're never wrong for starting off, obviously, with a conservative therapy with fiber as well as PT to get the distal physiology, pathophysiology corrected, and then moving on up there. And so that's all I can think of. So
thank you guys so much. I really appreciate it.
Yeah, but nice job, David. I
Yes,
think you did it. The pelvic floor one is tough. It's always tough because it's just so many different paths there. Yeah, and I can tell you, talking to folks in practice, a lot of people don't like to take care of pelvic floor patients because it's so complicated. So,
yeah, for sure.
nice job. I threw that one in mainly for the learning opportunity for everyone, and also because I got that on my oral exam. And the whole thing was if you didn't do a pelvic floor testing and you just treated the stool transient constipation, then you ended up with a complication. And then I was like, yeah, how you feel with that?
How heavily tested do you think that pelvic floor is for the general surgery oral boards?
Yeah, so I've seen that more and more on some of the general surgery boards. And then, so I can tell that our residents is something that we definitely go through with them. And it's mainly around what they are going through is the defecography, how do we work it out? But not necessarily. And then it transitions into the Altmaier, because that's something the general surgeon should be able to do. So taking care of rectal prolapse, but how do you rule out other things? But I was going to get us through that scenario real quickly and then get us to the Altmaier part of it. And that was where we're going to dwell on. Yeah.
Perfect.
Yeah, I think to be safe, having at least an algorithm there, I totally agree, obviously, with everything Gifty said. At least to be safe, having some kind of algorithm there would be, I think being prepared is probably the safest thing to do there.
Awesome. Well, we are just past 8 o'clock, so I want to thank you to our examiners and our examinees tonight for joining us and dealing with the torture of live recorded mock orals. We will be off this coming Sunday for both the car site and the general surgery oral boards, and back the following Sunday with Dr. Okuin from University Hospitals in Cleveland, who will be talking about operative management for liver mets and colorectal cancer. Have a good night, everyone.